moving on to the next topic, I would like to call upon Dr. Anuradha Parmesh, who is the consultant obstetrician and gynecologist at Anuradha Women's Clinic, Bengaluru, and Dr. Nishita R, who is the consultant geriatric physician and diabetologist at Sparsh Hospital, Bengaluru. We welcome you on stage, doctors.
Yeah, good morning everyone. Sincere thanks to Dr. Manohar and team for giving us an opportunity to be part of this 13th Disha Summit. And this topic for now is about hormone replacement therapy. Hot topic for all of us. So we are looking forward to listening to Dr. Prathima, Senior Consultant Obstetrician and Gynecologist at Sparsh Hospital, Bengaluru. Over to Madam.
Pleasure to be back at Disha today. Thank you to Dr. Manohar, the entire team, and lovely to see Anuradha again here. Pointer Idya. So Manohar asked me to speak about hormone replacement therapy, and the topic is, do you have a roaming mic at all? Pointer, sorry. Idya. The topic, of course, as you can see, that hormone replacement therapy is back. Now the question is, did it ever go away somewhere else? So through the ages, Aristotle defined menopause at the age of 40, and that was around 384 to 322 BCE. 1890s, and the French, of course, being the French and giving so much of importance to beauty and femininity, started doing animal extracts and started giving them to women for symptoms. 1942, there was conjugated equine estrogen, which a lot of people, I'm sure, in this hall have used in the past and continue to use. 1960s, the usage became mainstream. And this Dr. Robert Wilson produced a book, not really scientifically backed, about how you could remain feminine forever, because according to him, menopause was a disease. It was not a transition, but it was a disease. And obviously, women took this up. And if you can see what has been written here, that basically it promotes eternal health. 1990s, it became extremely popular. But then, of course, we have the Women's Health Initiative study in 2002, which said very clearly that the risks exceeded the benefits from the use of combined estrogen therapy, which means estrogen and progesterone, and this was followed up for 5 years, and then it was discontinued. So what do we have right now? And this is from where most of my advice and guideline comes from. Basically, we have the European Society of Endocrinology that has put forth a new clinical guideline for the management of menopause and the perimenopause. So a few definitions, just to go back to our basics. 1 year post the final menstrual period is determined as menopause, and this is a retrospective diagnosis. People will ask you, doctor, am I going through the menopause? And the answer is, well, not until you've completed 12 months of not having a period. What is an early menopause? Between 40 to 45 years of age is an early menopause. Perimenopause is the transitional phase where you transition from the start of menopause to completion of those 12 months of amenorrhea. Premature ovarian insufficiency, and it's now called premature ovarian insufficiency and not failure, is when you go through the menopause before the age of 40. So the question is, what is the average age of menopause in India? Well, it is given as 47 to 48, but most of the women that we see from the middle class and the upper socio-economic strata tend to mimic the West, which is about 50, 51. We have a lot of patients, and I'm sure Dr. Anuradha will agree, who go up to 50 and beyond without having gone through the menopause. So, slight change in hormone replacement and menopausal hormone therapy. So what is hormone replacement? which is the old terminology. It's basically used for the women that I talked to you about, less than 40, who undergo a premature ovarian insufficiency. So for them, it's a replacement, trying to mimic what nature has taken away from them. Whereas menopausal hormone therapy, which is what we're talking about today, is to be given around the age of natural menopause to treat the symptoms of menopause. We're not trying to replace it. We're not trying to make them forever feminine. We're not treating menopause as a disease. We're treating it as a natural physiological transition. So why is menopause important? I mean, how does it matter? Women go through menopause, men go through menopause, everybody goes through the menopause. But why is it important? They make up 51% of the world's population, which is interesting because they're slightly more than the men. By 2030, there will be about 2 billion people in the menopause. And that is a large number of women, 2 billion people in the menopause. And the British Menopause Society expects that 25% of these 2 billion women will suffer from debilitating symptoms and problems. So what are the symptoms of the menopause? Most evidently are the vasomotor symptoms, VMS. Mainly hot flashes, night sweats, and heat intolerance. And you have a lot of women coming to you saying, Doctor, I'm going through this and it's very, very disturbing, distressing at work, at home. They also have insomnia and headaches. Could the insomnia be due to the hot flushes that they suffer at night, or is it part of the hormone imbalance? It's difficult to say, but it's a combination of both. Psychological, you can see how many of these symptoms that women have. Now, brain fog is something that people constantly come to us about, where the actual imagination of brain fog ends and reality begins is a bit of a blur. I'm sure those of you who see women, have a lot of women coming to you these days telling you that I have brain fog, I cannot remember. And these are women who are in their early 40s. And you think to yourself, are they really having this brain fog, or is it driven by social media? And I think the truth is somewhere in between. Difficulty in concentrating becomes a problem, and slight losses of memory, which is not pathological. Genitourinary, again, is a huge problem. Vaginal dryness, dyspareunia, painful intercourse. They can also have urinary urgency, frequent urination, and recurrent urinary tract infections. This can be a problem for a lot of women, and remember, for those of you who treat such women, estrogen given locally or vaginally is helpful. All these are the physical and the body symptoms. Again, dry skin, hair thinning, weight changes, body morphology changing. Never forget that apart from the symptoms, one of the most important things is osteoporosis and the increase of fragility fractures, especially of the neck of the femur. And once a woman has a hip fracture, her morbidity increases and her mortality increases. We also know that at the age of 50 and above, a woman's risk of having cardiac events is equal to that of a man. So should menopause therapy be given? Menopause hormone, I'm sorry, that's MRT, that should be menopause hormone therapy be given? Yes. Vasomotor symptoms reduce up to 80%. Urogenital symptoms are helped, and osteoporosis is for treatment, remember, and not for prevention, remember, not for treatment. So you cannot treat established osteoporosis, but you can prevent it. What are the types of hormone treatment that we have? First, it must be holistic. You have to talk to them about lifestyle changes. Tell them not everything that they are undergoing is due to the menopause alone. That is the first thing to do. Also have an open and detailed discussion about what are the side effects and the benefits of hormone replacement and how long can it be used. So what do we have? We have estrogen, progesterone, a combination of both, selective estrogen receptor modulators, and alternate medications and therapies. We also have a drug called tibolone, which is a combination of estrogen, progesterone, and testosterone. This is a bit of a busy slide, but what is interesting here, yoga has shown no improvement in vasomotor symptoms, but has shown an improvement in psychological symptoms of the menopause. And physical activity, which our doctors talked about so much this morning, shows us there's a significant effect on vasomotor symptoms, severity, mixed results concerning the frequency. But it does help vasomotor symptoms, as exercise helps most of the gynecological problems that women suffer from. Hypnosis, again, seems to be pretty encouraging. So when do we start the hormone treatment? Within 10 years of the natural menopause, within 10 years of natural menopause, or under 60 years for bothersome menopausal symptoms. Now, let's say a woman doesn't have menopausal symptoms. Does she still qualify for hormone treatment? Yes, and this is to protect her bones. As I said, it reduces bone loss and reduces the fracture risk. When should you not give it? Primary and secondary prevention of cardiovascular disease. You cannot do that with hormone treatment. So don't give it for that. Don't give it to prevent a stroke. Don't give it to treat clinical depression. Don't give it to treat or prevent dementia. So a lot of our women are either obese or have hypertension or diabetes. Can it be given with hypertension? Yes. Diabetes, yes. Both should be well controlled. And also remember, for vulvovaginal atrophy, you can give local or systemic, and this problem is more widespread than the women talk about and what we actually appreciate and diagnose. What are the risks? Breast cancer. That is what the Women's Health Initiative study came up with. We have 5 extra cases per year per 1,000 women who take the combined hormone treatment for 5 years or more. So we're not talking about estrogen replacement therapy. And remember, estrogen replacement therapy is only for the women who do not have a uterus, who have undergone a hysterectomy. Because if you give unopposed estrogen, you will cause endometrial cancer. So it is with combined menopausal hormone treatment, and that is most probably because of the progesterone that we have this increased risk. Thromboembolism, more seen with the tablets or the oral route. Again, stroke, more with the oral route. Biliary pathology, and endometrial cancer, as I mentioned, with unopposed estrogen. So therefore, remember, if you have a uterus, protect it with progesterone. MHT for women with cancer. Breast cancer is a no. Uterine, ovarian cancer, discuss it with the oncologist, depending on their receptor status. And with cervical cancer, yes, you can give it because it's not hormone dependent. So what are the take-home messages? MHT has replaced HRT, not because we are constantly innovating and we have nothing better to do and it's all old wine in a new bottle. It's because we want to emphasize that we are not replacing anything in a menopause. We're only helping the menopause. When do you initiate it? Within 10 years of natural menopause and under 60 years of menopausal symptoms. Remember this, it is not an anti-aging strategy. It is not to keep you young forever. It is not to keep you feminine forever. And it should not be used for chronic disease prevention except to prevent your fracture risk. When should MHT be stopped? Now, most people would say that 60 onwards, of course you have to see your doctor every year, but 60 onwards, it's good to have a conversation because 60 onwards is when your risks of cancer increase. Regular checkups with your doctor whilst on the MHT is very important. Is it back? Well, it's more back in the news, in the social media. This lady has had several programs for this. I'm sure this lady did not use ERT or HRT, but I've just put that up there to say to you that forever feminine is not a concept for menopausal hormone therapy. Thank you.
Dr. Prathima, word on post-hysterectomy management with respect to
post what? Sorry, Dr.
Hysterectomy.
Post-hysterectomy management is estrogen therapy alone is fine. So estrogen can be given as tablets or patches. Yeah.
Whether it is
So if we have the ovaries conserved until they start feeling symptoms, we don't have to give it. But if your ovaries have been removed, then yes.
Thank you, ma'am, for that comprehensive coverage. One point I would like to add, because as a geriatrician, I see a lot more patients in the older age group who did not have access to menopausal hormone therapy as such. And it's a comment rather than a question. I would say that we have been using teriparatide, denosumab, and in these patients. And even though they have established osteoporosis, they do respond well to this. So that is one point that I would wanted to add. And another one, a quick question about what is your opinion about this bioidentical hormone therapy that has been going around, ma'am?
So scientifically, the bioidentical has not been proven to be useful. So right now, we wouldn't prescribe it. We have people, I've taken bioidentical from various other people, but scientifically, there is no support for that. Yeah.
Thank you, ma'am. Thank you, ma'am.
Thank you.
So I don't think we have time for questions, but we can discuss with ma'am over lunch or coffee. Thank you so much.
Thank you. Thank you so much.
Thank you.
I would request the chairpersons and the speaker to move towards the selfie area for the group photo and the memento. Moving on to the next topic, I would like to call upon the chairpersons